ready? You got me running.
I am Meredith Hirsh, and this is Working Healthcare. Today's conversation is different. It touches a kind of heartbreak that can be hard to hold, but it is also grounded in what we can do, especially in healthcare. I just interviewed Erin Williamson, who is the Chief Programs and Strategy Officer at Love 146. It's an organization working to end child trafficking and exploitation. Erin is a licensed social worker. She's also married to a pediatrician, and together they are raising their two preteens. If you work in healthcare, you may be the one safe person a child sees that day. And what you notice, what you say, and what you do next can change the course of their life. Erin Williamson, welcome to Working Healthcare.
Thank you so much for having me. It's great to be here.
This is a very different topic for working healthcare, but it definitely relates to the medical community. First, you're a social worker. You actually have your master's degree in social work and in public health. Tell me a little bit about your background and why you chose to even go that path.
Yeah, so I went to undergrad. I got my BSW, Bachelor's in Social Work, and went and studied abroad in Kenya and really thought I was going to do international work. So I went back and got my master's. It was in public administration with a focus on international work, and did one of those if I just go for one more year, I could also get my master's in social work because they had that one advanced standing kind of thing where you can go for a single year, and had no idea that the intersection between those two degrees was going to be so important, because it really is like the micro and the macro, and understanding the individual care and also the systems that impact individuals. And it's just, it's been a ride, but I've definitely used both of those degrees, and it's been so helpful.
You and I have a very similar background in the sense that we moved a lot as children. My claim to fame, one of my multiple claims to fame, I lived in 13 houses by the time I started high school. And when I asked you where you grew up, you answered the same way I do, everywhere. And I said, did we talk about this? Do you think moving around so much as a child impacted your decision to go into social work or to go into the career in which you chose?
It definitely impacted my ability to talk to anybody and to make relationships and to feel super comfortable in new situations. And it probably is tied. Both of my parents were kind of in that helping profession world. But my father passed when I was pretty young, which also prompted one of the many moves we had. And I definitely think, being part of, he unfortunately got cancer when I was 8 and passed when I was 10. But for a large part of my childhood, I spent, in healthcare, right? In hospitals, or getting my own therapy, and watching kind of that profession. And so I think I grew up among helpers, and I experienced the benefit of helpers. And so I think it certainly drew me to wanting a career in which I felt like I was also helping people.
And you moved throughout the U.S. and you thought you would go to Kenya. So I guess you had enough of our 50 states and you're like, I'm just going to go to another continent. And you actually finished your schooling in D.C. and worked in D.C. for a long time. I always think it must have been impactful to have studied, especially social work, in our nation's capital, and all of the disarray, honestly, that goes on, not just politically, but there is a huge discrepancy between wealth and poverty. And there's a lot of crime, as we hear multiple times with Trump sending in the National Guard. But how did it even impact you going to school in D.C.?
Yeah, it was fascinating. I had studied abroad in Kenya. I lived in Mexico. So I had experience. I'd worked with street children in both of those places, which was kind of what drew me to trafficking and understanding child exploitation. And so I had seen kind of abject poverty, really, where it's just bare, kids living on the street. And then to come to our nation's capital, to your point, where the disparity was so great, right? You would see people coming off of the Hill dressed in very nice suits, going out and having martinis and having really nice dinners. And then, you would also just a couple blocks away see people really, really struggling. And certainly when I did my social work placement, I worked with kids who were in a group home, and hearing about their lives and what they were experiencing. It was very the different perspectives on kind of being in a world that was both so local and national and global, and hearing people talk about it so differently was really, really eye-opening. And also really, again, the micro and macro, you could hear people talking about how do we address these large things like poverty or inequality in education, and then you would experience it right there. And so I learned a lot. I still have tons of friends there who I talk to regularly. It is, though, its own bubble, right? Now that I am out of DC for 10 years, when I talk to people there, I can really see how you do get in this bubble that you don't even realize exists, where you're not as aware of kind of how things are playing out for the vast majority of the country. And so I love my time there. I was there for 10 years. I'm also very happy to have left and to be now upstate in Connecticut.
You're in upstate Connecticut, but you're still part of that Northeast culture. So I'm sure you certainly feel the ramifications or the tentacles coming out of DC up where you are. We were supposed to meet in mid-November for the first time, and you had to cancel at the last minute because you had a press conference. So share what you're doing in your life right now and all of the work that you did in social work and in public administration into what Love 146 is and what your passion project is.
Yeah, absolutely. So, I was hired by Love 146, which is an international anti-trafficking company organization, to build out a program in Connecticut to serve kids in Connecticut who had experienced trafficking. And, it was just me. It was one of those jobs that was, totally unrealistic, build a statewide program and do policy and the direct service and all the system stuff. So, really thrown into the deep end of it. That program now has over 20 staff, and we've served over 1,000 kids. And now I also oversee our prevention education program, which is in over 30 states. That program's called Not a Number. And so we kind of run the gamut of everything from trying to give kids the resources and tools to recognize red flags, right? Where trafficking has really changed over the last 20 years. It used to be something that required kind of face-to-face interactions, the grooming and recruitment, but online digital media has really shifted both how kids are exposed to grooming and recruiting, and then also how exploitation occurs. And, so I still am connected with the direct service work and have a lot of staff. And then, we do, as we've seen in the news lately, there are, high profile cases, high profile individuals that are connected into trafficking. And we do try to get out there in front of the media as much as possible, because it's one of those things that people just still continuously don't realize it does exist in every community, right? We still kind of think either it happens over there in those other countries, or, oh, it doesn't happen in my neighborhood. And I say to people all the time, I live in Connecticut. It's thought of as a very wealthy state, right? We have Greenwich. We have these, people who work in New York City. And we have worked with kids in every single county in the state. We have, pulled up to houses where poverty is a major factor in their risk factors. And we've pulled up to mansions. And those risk factors are different, but it doesn't mean that kids are not being impacted.
And people listening to Working Healthcare and those regular listeners may sit back and say, Why is Erin Williamson on your podcast? And I very much wanted you on this podcast. Not only is January Human Trafficking Prevention Month, but this definitely interplays with our American healthcare system. How does it do that, Erin?
Yeah, no. And in fact, healthcare providers are one of the primary places that identification can occur, right? Because, even though these individuals, I think a lot of people have this misperception that kids are kidnapped and held against their will and they can't access anything. And the reality is it's much more complicated. Usually there's a lot of coercion. Many times these kids are still living at home and they'll run away and spend time with their trafficker and then they'll come home, or they're involved in the child welfare system, but they are still coming into regular contact with that healthcare system, either through primary providers, through minute clinics, or sometimes through the ER. And, sometimes there really are opportunities that exist in the healthcare setting to peel back some of the layers and ask some of the questions that other people can't normally ask, because you're asking as a healthcare provider, right? You're asking, how did you get that mark, or do you feel safe at home, or other questions that it wouldn't make sense for other people in their life to maybe ask. And, we've had many kids say to us that, there were certain healthcare providers that kind of opened up that door for them to disclose what was happening. And that's both in those, medical systems. It's also, as school nurses are a prime example. And so healthcare is critically important. My husband is a doctor. He's a pediatrician. And because of the work I do, he's very, well-versed in trafficking. He works with kids who have cancer. You might think those worlds could never intersect. He has called me on a number of occasions, concerned about the kids who are seeking treatment from him for cancer, that they're also experiencing human trafficking.
How does he identify those patients?
So sometimes they come in and, and they're not allowed to say much, right? Especially adolescents, where normally an adolescent would kind of take over at a certain level their care, not fully, but they would play a major role, right? They're becoming independent. They want to share their own experience. And yet these adolescents maybe don't say as much. Maybe the adolescents are showing up with a lot of STIs, and he's wondering, well, okay, I get that maybe doesn't have anything to do with their cancer treatment, but it's still curious that an adolescent is having so many STIs showing up in their medical records that I'm seeing. And so, he'll spot certain things that, again, I think you could quite easily overlook. But once you start asking questions, right? And it doesn't have to be invasive questions or accusatory questions, just curiosity with no judgment, right? So I'm seeing on your medical records that you've had quite a few illnesses that have come as a result of kind of sexual intercourse and experiences. And I'm wondering, what's happening there? Can you tell me how this is happening? Is this, and you're just leaving that door open. Is it one individual you're having the relationships with? Is it multiple individuals? And trying to do it in a non-judgmental manner can lead youth to start to disclose things that, again, then you're kind of following that thread, right? Are these individuals that you're meeting online? Are these individuals that you're in long-term relationships with?
Erin, how do you ask those questions if the perpetrator is in the room? Because I know, I have 3 children, and I know that when I've taken them to the pediatrician, I'm in the room with them. And there have been, I think, 1 or 2 occasions maybe where the pediatrician has said, I really want to speak to Benjamin, Ethan, Dalton by himself. But typically, the parent or the custodian is in the room. So how do you circumvent that?
Absolutely. And I think you just mentioned how they do it, right? So-and-so is now 12 years old. And usually once we hit 12, we try to have some conversations that are private. Is that something you're comfortable with? I can invite a nurse in, so I'm not alone in the room with them, so there's multiple people. And I do think, kind of as parents, we do know that at a certain age, kids often do have private conversations with their healthcare providers, right? But to your point, that's another indication. If you do have concerns that maybe a parent is trafficking them, or maybe they're being brought in by a significant other and you're concerned there's trafficking, seeing how that person responds, right? And asking, like, what are your concerns? Are there ways we can mitigate them, right? We've had a lot, it is not uncommon, for example, when a youth shows up at the ER, right, that they will show up with their trafficker, in part because, their trafficker's concerned that they're going to share something, they're going to disclose something. And so figuring out how to how to separate those two individuals of, oh, you came in. Oh, you're saying you guys were in a car accident together. We'd like to do an exam on you as well. Can you come into this room? We just want to look you over, make sure you're okay, right? So figuring out kind of how you can separate to ask those couple of questions, even the "do you feel safe" questions, can be really important.
And I'm going to ask this from a provider's point of view. There's so much regulation going on right now, and there's so many boxes to check that even when my kids get their form, right, are they depressed? The form is given to them to fill out in the waiting room before they're brought back by the nurse. And I don't even know if it's really reviewed much by the doctor ahead of time. And now you're looking at doctors or nurses or healthcare providers and saying, hey, we're going to give you another piece of responsibility to look out for, because you deal with children, but we're also talking about adults who are trafficked. And every time I go to the bathroom in the airport, I see the sign on the back of the door that is in multiple languages that says, hey, could you be trafficked? And this is the sign, this is the code, and so forth. I've seen that many times. I don't remember what the code or the sign is. But what is expected of healthcare providers in a legitimate way?
Absolutely. And it's not just healthcare providers, right? It's teachers. It's what we're expecting of kind of anybody in a helping profession. And it is a lot of information, a lot of expectation. I think the most important thing for healthcare providers is to recognize that this could be something that's happening, right? I don't think we can expect healthcare providers to, know all of the things that are going to be happening and ask all the questions. But just like we want to get somebody to the point that they might make a mandated reporting call, right, for a child, or they might ask somebody, hey, can I have a social worker come down and talk to you a little bit more? We want them to recognize that this could be something that's showing up in their patients' lives, right? That if they are seeing, just like domestic violence, right? We've talked a lot about, what does domestic violence look like? We didn't used to think or talk about, well, what does teen dating violence look like, right? We talked about it only with adults, and now we recognize, oh, that type of violence in relationships can happen even at younger ages, right? And this is another thing. Oftentimes, trafficking does get mistaken as either teen dating violence or as child sexual abuse, because people don't realize the commodification that goes along with that. And so, one of the things I would say is anytime you suspect teen dating violence, anytime you suspect child sexual exploitation, recognize that there also could be a commodification that's going along with that. And especially if you're in a longer term relationship, it depends, I think, on what is the purpose of that relationship and that visit, right? If you're an ER doctor, identification is your focus, right? But if you're a long-term provider, whether it's mental health or physical health, then you're going to have different goals, right? It might be dealing with the physical trauma that occurred during the victimization, or dealing with some of the mental health trauma that occurred. And so those are places where understanding how commodification impacts the body is really, really important.
And I want to talk about that, because you don't just work with children who are sex trafficked. You work with children who are trafficked. And you explained to me it was the commodification of it. Can you explain that to our listeners, the differentiation, and when it's trafficking versus when it is not trafficking in something that is not sexual abuse?
Yes, absolutely. So when we talk about kind of this larger definition of what is human trafficking, it typically gets broken down between sex trafficking and labor trafficking and adults and children. And how it is defined and looked at is almost in these four quadrants. So if we first take, because it's much easier for people to understand sex trafficking, most people come into this issue through that. So if we first look at sex trafficking for children, really, under the definition, it is any kind of commercial sexual act for anything of value falls under that legal definition of human trafficking. So it could be, for example, we have had children where they are actually sold online, there's advertisements, or they're sold in their neighborhoods, and it is kind of what you would call, if it were an adult, you might call or think of as prostitution, right? And sometimes there's a third party, and sometimes there's not a third party. And that third party is kind of arranging those encounters, those quote unquote dates. Or really what we say is those rapes, right? Because it's children when we're talking about it. In those situations, you don't have to prove force, fraud, or coercion. And the way to remember it is there's no such thing as a child prostitute, right? That doesn't exist. Anytime you're thinking of a child and you're thinking of the word prostitution, it falls into human trafficking, right? When you're talking about adults, the law is different, right? There does need to be force, fraud, or coercion, right? Because there are such thing as adult sex workers and adult, right? And so that's the differentiation between children and adults, right? Now, let's go over to labor trafficking. Labor trafficking can look in a myriad of forms. There's both the underground labor, right? The illicit labor that could be drug dealing, that could be selling things, under the table, working under the table. And then there's the above ground economy. And that's where kind of you have a W-2 form and you fill it out and taxes are taken out. And the government knows about whatever is happening, and it's a legal contract that it's happening under. Trafficking can actually happen in both of those situations, right? You can have somebody, for example, and we've worked with individuals in this situation where maybe they're working at their local supermarket, but when they get to wherever they're staying, somebody's taking that check away from them, and they're not able to see any of that money, and they're being forced to do this, right? And so they're going into kind of the labor market, they're earning money, but they're not keeping any of it, right? And they're being forced. Then underground, we see this with drug dealing. Sometimes you might see, for example, kids selling candy, right? And they'll say that it is for raising money for, their soccer team or their baseball team. And sometimes it is, and sometimes it's not, right? Sometimes these are kids that are forced to go and sell candy. I remember when I was in DC, we worked very close to an area that had a lot of bars, and you would see kids dropped off there at night with bins of candy that they would go into the bars and sell, and then they would all be picked up at a certain time, right? They had quotas they had to meet every night, right? That's trafficking. The magazine crews that you might see coming around your neighborhood selling, that can be trafficking. With labor, you do need to have force, fraud, or coercion, right? Because you can work. It's legal to work. It's even legal for children to work, right? And so you do need to be able to prove that there's some kind of force, fraud, or coercion in order for it to move from just labor exploitation to actual trafficking.
How do you differentiate? And I this might be a really immature question, and I don't mean for it to be immature, but you have kids who could, quote, babysit, right? At 10, 11, 12. You have other kids who can work, not necessarily getting a W-2 or certainly not a 1099, but who are working outside of the home, and they give all of their money to their parents to help support the family. How does that differ?
Yep. And so you really need to, in those situations, figure out, right, what are the circumstances around that? Does that child have a choice in doing that, or are they being forced to? There have been examples just a similar example to that of children who have gone into the foster care system, especially in rural communities, and been expected to work on the farms, right? And then they stop going to school. And then when they maybe say to their foster parents, I miss school, I want to go back, they're told no. We have expectations. If you're living here, you're expected to contribute to the family, right? That would then start to fall under that definition of human trafficking, right? Because they don't have a choice. There is a forced mentality. Kids do have the right to go to school. So if you're seeing kids that are starting to miss school, that are starting to not get their basic needs met, we have laws in place that adults are responsible for certain things for children in their care. And if those things are being neglected and instead kids are forced to make money and give it over to the family, then that does fall into that trafficking zone. But some of these cases, there really is, when you think about the spectrum of even just legal labor, it does fall into this gray zone before it's so clearly trafficking, right? And sometimes we do find these cases where it's very exploitative, it doesn't feel right, but it maybe isn't legally trafficking yet.
What do people do when they see any type of human trafficking, or they have and I'm specifically thinking of those in healthcare, when they have an inclination that something is off, something just isn't right? What do people do?
Yeah. First, the biggest and most important thing you can do is try to be non-judgmental and try to get across to the individual in front of you that you can be a safe person if they want to disclose anything to you, right? A lot of times we'll work with kids and they'll tell us things that have happened. And one of the first things they'll say is, you were the first person I told this to because I felt like you could handle it, right? So often, disclosures don't happen because kids or adults don't want to put that burden onto somebody else, right? And so part of what we can do as, serving as healthcare professionals, as people who interact with various populations at risk, is kind of to ameliorate that fear that they're burdening us or that we can't handle it. And then the reality is that, to a certain extent, we do need some sort of disclosure, right? We can ask all these questions, but for those of you who have worked with, children in particular, there's a lot of times where you might have a hint that home isn't safe, but not enough has been shared for you to take that next step, right? And so those can be really hard cases, right? And sometimes we are waiting for those youth to disclose if there's not enough for us to go on to kind of take that next step to secure safety.
And you and I are extroverts. You and I could talk to anybody. Maybe it's our upbringing. Maybe it's I was raised by a social worker. You are a social worker. And and we can have those conversations. But a lot of people are not comfortable having those conversations and just want to call somebody, just want to say, hey, I saw something, I need to say something, right? We're all taught, you see something, you say something.
Absolutely.
What do people do? Where's the first phone call?
So there is a 1-800 number. There is a National Human Trafficking Hotline. It's 1-888-373-7888. Depending on how much information you have when you call that hotline, or whether you're calling, your state child welfare agency, they may or may not be able to move on the information you're giving them. And so, one of the things to think about, especially if you're working in a larger medical environment, is there somebody that you can say, give me 1 second. I'm going to go get Nancy. Nancy sometimes meets with some of our patients and asks some additional questions. And maybe Nancy is your colleague who is super comfortable having these conversations and might be able to elicit a little bit more information that might then help when you call that hotline. Because I will say, when you call that hotline, if you simply say, I have concerns about this individual, but there's not much else to go on. The hotline can't oftentimes do anything, right? They'll say, call us back when you have more information, or you'll get a non-accept into the child welfare, hotline. And so there is kind of that balance of, do you have enough information to make a report that's helpful? And if you're not comfortable having those conversations, who can you then rely on? We actually talk a lot about this with therapists, right? I think all of us who were trained as therapists want to think, well, ideally, if somebody sat down in my office or someone sat down with me, I would want to be able to help that individual. But there is a real empowerment in knowing who you are comfortable with and who you are not comfortable with. And the truth of the matter is, not everyone is comfortable talking about trafficking, especially sex trafficking, right? Not everyone's comfortable talking with children about, really horrific things that have happened to them. And what a service it is if you can be that therapist that says, I have a colleague that I actually think you would be great to work with. I know I'm going to look for someone I can refer you to.
And even if you're a physician or a pediatrician and it's a doctor's appointment and you do contact authorities because you do have some information, and this actually has to go with the press conference that you were involved in back in November, on November 14th specifically, and these children are moved from place to place to place. And so how are they even found?
Yeah, you're absolutely right. And I give a lot of credit to our law enforcement officers. They have a lot of resources that they tap into. There's the National Center for Missing and Exploited Children is a national network that we partner with a lot. They are often able to, make sure that all law enforcement across the country are aware when children are missing. So, for example, if a child goes missing from California and shows up in Colorado, and somebody interacts with that child, they will know this is a missing and endangered child, right? And so, we do really rely on law enforcement to use all of their tactical power, and also the community, right? There's a lot of times where, if you go on social media, you will hear about individuals that are missing or people are worried about. Have you seen this person?
Oh, we get
right?
Amber Alerts.
Exactly.
And so there are ways to do that, and there are ways to definitely see and track down these people. But I would think that most of the phone calls made to the Human Trafficking Hotline probably don't go answered because there isn't enough support, or there probably isn't even enough help to seek out those individuals.
And one of the reasons that I think the hotline's so important is because also survivors can call themselves and victims can call themselves, right? And so the hotline also receives calls directly from survivors and victims. One of the things that you can do as a healthcare provider is you can give out those hotline cards. You can give out those 1-800 numbers. I will tell you, those of us who are kind of quote unquote in the know that there are hotlines out there, most people don't realize that there's hotlines out there, right? Most kids are unaware that there's a runaway hotline that they can call if they need help, or that there's a hotline they can call if they're worried that their friend is addicted to substances or alcohol, or they're having suicidal ideation, right? Kids are not aware, and even adults are not aware that hotlines are out there. So if you don't have somebody in your family or in your community or your neighborhood that you feel comfortable talking to, you can call into these 1-800 phone numbers and get resources and get information. And so, the hotlines, I think, serve a multitude of purposes, not just for reporting something that might require, urgent law enforcement intervention, but also for, helping the neighbor figure out what should they ask the person that's working in the house next door to identify, is that person, domestic servitude? Are they being held against, being forced to kind of do housework and not getting compensated for it? What are kind of things that the hotline might need to know before they send law enforcement in? So again, if you're that person and you're not sure, well, what do I need to ask? How do I ask that? Those are also good times to call the hotline.
And Pete, we talked about how these people could be even parents or they could be foster parents. People also imagine trafficking as strangers or abductions that happen. But in real life, how do kids get pulled in? What makes the grooming process so effective?
Yeah. So definitely, as hard as it might be for many of us to believe, we do see a number of kids who are trafficked by their family members, right? Who are trafficked by parents, who are trafficked by uncles, by other individuals in their family. And certainly there's a whole thing that goes along with disclosing that because, you can replace a boyfriend, you can't replace a mom, right? And so there's a whole nother layer of disclosure and of what goes on with that. But when we're not talking about someone who already has a natural relationship with you, be it, your family or your church or your school or even your sporting team, there are a lot of people who, will put themselves in places where they meet individuals. And I think I was saying to you before we got started, the internet has just fundamentally shifted how people have access to our children. And so, it used to be a very small percentage of our kids were identifying or finding their trafficker online. And now traffickers are finding children online. And about half of our kids have their first interaction with the trafficker online. One of the challenges we face as parents, right, is if we simply say, don't talk to strangers online, well, by the time that trafficker is exploiting that child, they're no longer a stranger, right? They're their best friend. They're the only person that's ever understood them and known them, right? And so, we have to kind of move away from this stranger danger or, because part of the grooming process, and this is true for trafficking and all forms of kind of sexual abuse, is forming a relationship, is getting to that point where you're leveraging that relationship as part of the exploitation.
You talked about, or we talked about what happened in Connecticut when you and I were supposed to meet, and it was 3 14-year-old girls. And they were actually lured from their home and they were moved to multiple areas before the police actually identified and were able to, I think there were 7 people who were arrested, 7 guys who were perpetrators who were arrested for them. Now, what happens with these 14-year-old girls? Where do they go?
Yeah.
What do they do? And how do we bring them back into society?
Yep, absolutely. And so, when the parents or caregivers are not involved in the trafficking, right? You really need to support and resource that entire family, right? Because not only do you have the children that have experienced this horrific victimization, you have these parents who oftentimes have no idea that this could have ever even occurred to their child, let alone know how to support that child, right? And the reality is really talking to both that child and that parent that this is going to be a journey that they're going to be on, right? And unfortunately, the journey isn't linear, right? It's not like every day it gets a little better. The goal is not to think short term. The goal is to think long term, right? That while this thing feels so huge in their minds at this moment, like they're never going to think beyond what has happened to them, that in 3 years, it will feel smaller. And in 10 years, it will be something that happened to them, but it won't define them or who they are or what they did with their life, right? And not that it's ever going to go away. It's not. This is a horrific exploitation that doesn't just disappear, right? But that its place in your life and the narrative of who you are and who you become, you have some say in that, right? You have some say in how much space it takes up and how little space. And part of that is through therapy, and part of that is through understanding what happened to you, right? A lot of times, there were a lot of articles about that case that you're talking about. And one of the articles, it said, a joyride gone bad, right? Like, that's one way to think about it, right? And if that's the narrative that a youth has, they're going to think maybe about joyrides differently. Or were those kids set up, right? And so I think that we need to, part of your work long term with those youth is to figure out, okay, what has physically happened to you, right? And then also what has emotionally happened to you, and what do we need to work on through therapy and through support systems. And then, sometimes you're dealing with families where there's intergenerational trauma, right? Imagine if any of those mothers of those kids had also experienced childhood
Well,
sexual
that's what I want to get to. So you have parents or maybe split households where they actually don't have the ability to take care of their children, okay? Either they are neglected and children find a perpetrator, or when they come back into the home, the family does not have the resources, monetary or even emotional breadth, to be able to support these children. What do we have in this country? And you and I talked a lot about Minnesota before this podcast episode because you spent a chunk of your life in Minnesota, as did I. And my mom, as a social worker, when she finished her schooling, moved us to Minnesota because they had such great mental health care at the time. Now, this is 1980. Right now, I don't know if we have those resources. Where do parents, or where do these children or pediatricians or anybody involved in overseeing or looking from afar to these children, where are the resources?
They are inequitably distributed, as are many resources, right? You can have communities that have great programs. Those tend to be more urban populated areas. And you can have communities where there's almost no resources, and accessing them is very difficult. Telehealth has brought some access to people who are in more remote areas. But, I have 40 kids right now waiting on a wait list for long-term services, right? Those are 40 kids that have experienced some form of exploitation that everyone agrees needs our long-term services. And we just don't have enough funding and staff to meet their needs. And that's the reality. And sometimes what happens to those kids is that they're re-exploited before they get off the wait list, right? We do not live in a system or in a society where we are providing enough resources to these children, especially because their needs are so complex, right? I'm just going to give you one example. So you have a child who's been exploited. They've been sold, right? Their body has been commodified. Maybe they were sold alongside other children. Maybe they were sold at different prices based on their race, or based on how pretty they were, or based on something else, right? Now you have that child, they're going to turn 18, they're going into the adult world, and we're talking to them about getting a job. Well, why am I going to go and get a minimum wage job when I know how much I can earn in one night?
Mm-hmm.
That's a very valid question for that child, right? That child knows how they can get money if they need it, in a way that other children their age do not know that, right? That is a valid question that we have to be able to work through. And we have to talk to them about what kind of life do they want to create. Because they're right. They can go make that much money in one night. But that will lead down one path of life where if they start with a minimum wage job, but they get on a career path where they have opportunities for advancement, that will lead down a different path. There is autonomy that they have in making that choice. But it's our responsibility to sit alongside them and provide them with all of the information so that they can make the best choice for themselves. And also to sit there non-judgmentally, so that if they make a choice that they then say, that actually wasn't a great choice, I want to change my mind, we can say, that's fine. Let's now make a different choice and try again, right? Those are very, very resource intensive services. But every kid who's experienced trafficking victimization deserves someone who can walk them through that.
But we don't have enough resources. And I used to teach high school English and journalism in inner city Miami. And I said 25% of my job was being a teacher, 25% was being a social worker, 25% was being a friend, and 25% was being a mother. I had a kid call me to bail her out of jail. I had a kid who I wanted to stay after school as late as she could with me and did not want to go home. There were times when I brought it up to administration and nothing was done. Literally, after my first 4 months teaching, when there was winter break, I didn't know if I could go back. And that was pre-children. I now have 3 children of my own. I could not imagine doing that day in and day out. How do you continue to do what you do, Erin? Because I know that you have 2 young children. And how do you do that? How do you encourage those who are listening to the podcast not to get burned out, to continue to fight the good fight, and to create change within our American healthcare system?
Burnout is real.
Mm-hmm.
And the difficult work that we do is real, right? I said earlier, my husband works with kids who have cancer. His specialty is brain cancer, right? We're a super fun family, right?
Yeah.
Super fun at parties.
So hard.
We've made certain rules in our house, right? We do our best not to bring work home. If one of us can tell that the other one is still, like, their mind is still at work, we'll say, go up and go get in pajamas, right? Like, physically take your clothes and change them so that you can come and be present. The benefits of having children, and we have 2 of them, are that they don't care what work you do, right? They want you to be present, right? But I remember changing my daughter's diaper and thinking, we have kids in our partner program in Philippines who just came into care who are this age. How do you sexually abuse a kid this age? And I had to literally say, you have to stop thinking about that. This is not your child, right? It's hard. There's no one way to do it. There are times where I'm thinking, I can't do this anymore. I need to stop. And, I'm fortunate enough that at Love 146, we offer sabbaticals, right? So every couple of years, I get a month paid off. I think that things like that are really important in work like this. It is why we don't have as high of a turnover as many other nonprofits do. But it is why it's really important that you know when you need to stop doing this work. We have had people who have said to us after a year or 2 on this job, I can't do this anymore. And there's no shame in that, right? There's absolutely no shame in saying, I need a different role for myself, for my family, for the longevity of this. And again, I think that that's really healthy to know that about yourself. And the other thing, I recently read a book, and it's called Too Much. It's a great book. It's about kind of people who are, codependent, and in part because they're caretakers, right? That's their codependency. And one of the things it talks about is, like, you really need to reassess what your boundaries are at different points of your life, right? You're going to have very different boundaries in your 20s than you are when you become a parent, than when you're in the sandwich generation and you're caring for your parents and your kids, than you are when you're at an older age. And I think reassessing your own boundaries and what you need in your life is really a valuable exercise that probably we should all be doing about every 6 months.
And January is Human Trafficking Prevention Month. And I want to wrap up this podcast. And my key question is always, if you could create one change within the American healthcare system, what would it be? I want to pivot a little bit and ask you, if you could have an impact with our listeners, one thing, one takeaway that you want from our listeners from hearing about Love 146 and child trafficking and how to prevent it, what is that one takeaway?
It's somewhat of a combined takeaway so it's two things. I'm going to cheat a little and say 2 things and merge them together in hopes that they can become one. I think when you think of that child that came to you and didn't want to go home, right? Or when I think of the kids I've worked with who've been trafficked, it's so hard. It's so easy, I think, for us to think that is such a horrific thing they went through. And that in some ways that also kind of defines who they are. And at least in our minds, right? So people will hear trafficking and be so horrified and think, oh my gosh, you've experienced trafficking. That must be have been horrible. And what I want you to know is that these are kids that still laugh, that still have fun, that still are resilient, that many go on to have families of their own, right? To have experiences that even these kids, and there are so many kids, when you really think about how many kids experience some form of child trauma, there are so many adults that are in our world who grew up and experienced child trauma. And there are probably people listening to this podcast who are drawn to the healthcare setting, who experience child trauma. That is not define who they are. It does not define who they can become or what they can do. Does it mean that it is part of their story? Absolutely. Forever, it is a part of their story. But absolutely, it is not their entire story. It's a page, it's a chapter, it's a sentence, it's a period at the end of the sentence. Just please know that when you come across any child or any adult who has experienced something like this, as easy as it is for us to automatically explode this event into their entire story, that so often, right, people are able to move on and successfully write the rest of their story beyond just having experienced that horrific tragedy.
Erin, I thank you so much for sharing your life experiences, sharing what you do every single day, helping children, raising your own children, even what your husband does, and supporting him throughout all of that. But you are an inspiration, and I thank you for joining me on Working Healthcare.
Thank you so much for having me. It was great speaking with you.
If this conversation hit home or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post about it on social media. Connect with me on LinkedIn to keep the conversation going in between episodes. If you've got a question, an episode idea, or someone you think I should feature, send me a note at meredithhirsh.com. Thank you all for the 5-star reviews. They help more listeners find the show. New episodes drop every Tuesday. Subscribe so you don't miss what's next. Tune in weekly as we explore the inner workings of healthcare, because you can't fix what you don't understand.